Welcome to part one of our three-part series where we deep dive with our leading expert, Dr. Tommaso Falcone. Let's dive in.
Okay, thank you so much. Now, your list of credentials is incredibly impressive and inspirational, as I mentioned before. You are certified by the American Board of Obstetrics and Gynecology, the Royal College of Physicians and Surgeons of Canada, and have been appointed Fellow ad A&M of the Royal College of Obstetricians and Gynecologists in the United Kingdom. How do you feel approaches to obstetrics and gynecology differ between those countries?
So the approach, these three health systems, it's not the treatment of a disease that is different. So if you have a cancer, for example, you would be the same whether you're in Canada and the United States if you follow the guidelines, and even in the UK. So we all agree here, sitting around the table. If you have this, we would treat these, and that's because of the international flavor of the medical literature, which is meant to be read by everyone. It's in fact access to care, which is the main difference between these three systems that I've actually practiced: Canadian, American, and British. Um, the and so therefore, you have access in the national health system in the UK, which has very good medicine but very difficult access. In Canada, it's the same. In the United States, um, the public health is administered by private organizations rather than having a building that is owned by the government. Some of them are owned, they're very few. The way it works here, the public system is almost like an insurance policy, which is given by the government. So the government of the United States says all hospitals who provide care, we will pay for their access to care, and that is called Medicare and Medicaid. Okay, so this then is the way patients access, but all the infrastructure is owned privately, and privately could be not for profit or for profit. Yeah. Like the Cleveland Clinic is not for profit, but we are private. So therefore, access to care is the main difference between these three systems. And again, the British one's closer to the Canadian system. In the British system, in fact, you are allowed to have private medicine for everything. You can have heart surgery in private hospital or in a public hospital. In Canada, you cannot. You must have it in a public hospital. In the United States, they're all private hospitals, but who pays the bill is the government over here. Small access to care is a different approach in each country, and each has a limitation, which we can discuss further, but that's the main difference between the systems.
How do you think that's different for you as a practicing physician?
So as a practicing physician, if you're in Canada or in the NHS, if someone says, "Oh, Mrs. Jones, you had endometriosis, and I think we should have surgery as an approach." Well, you're going to wait a long time in Canada when I was practicing there, or in the NHS. I did not practice in the NHS, but I was practicing practice. In the United States, if the patient says, yes, Mr. Jones, you have endometriosis, you have to operate, we can do it next week or a week after. Now, in the NHS and Canadian system, we never discuss whether you can afford it or not. You will be scheduled, although this will be in 6 months. So here, I will give you the surgery. I can get the surgery pretty much whenever you want. However, your insurance company pay for this. And if the patient says no, well, then I can't treat you at all, unless you're willing to pay the bill. So there's the main difference between that. So if you have insurance, if you have Medicare, certainly over 65, everyone has Medicare. You will get you in because according to the law, you have to, whether you have private medical insurance or Medicare, it's government, where you have to treat patients the same way. It's morally the right thing to do, but it's also illegal. So access to care, again, is the main thing. So you either wait if you're in a public system, and in Canada, my patients always waited a long time, which we don't do here. However, they all got it ultimately, which here they may not because of the cost.
Yeah, it's interesting, and it must be, you know, different for you working in the different places to be able to approach those things. And I guess you've seen things from lots of different perspectives, which can only make your patient care a lot richer.
Right. And so you always you have to discuss, so for example, if a patient needs um, in vitro fertilization for their endometriosis, or they need egg freezing, because they're going to have surgery on the ovary, which may compromise their fertility. So the egg freezing is has cost. So in Canada, the IVF cycle could be paid for, and therefore this patient can't proceed. In the UK, the public systems, they can also do the same thing. In this country, depends where you are. If you're in a state or you have insurance that covers it, you would do it. But if, let's say, a patient does not have insurance to cover in vitro fertilization, which should cost them $20,000, then and the patient has pain, then our management of that patient is influenced by the fact that because she cannot afford to, if it's some that most of them can't, but if they cannot, then we are basically doing a more interventional surgery for that type of patient that you would otherwise not do if you were in another country. And again, it's a personal decision. It's a shared decision-making process with the patient. Because the patient may say, well, if the right thing to do is to do the IVF, I will use my credit card, or something of that nature.
Yeah.
But it does go into the discussion piece.
That wraps up part 1 of our series. Thanks for listening. Be sure to join us for part 2, where we continue the conversation and uncover even more valuable insights.